Hello, and welcome to Patient-Centered GA Care, synergistic approach to optimize management. I'm Dr. Stephen Ferrucci, Chief of Optometry at the Sepulveda VA Ambulatory Care Center in North Hills, California, and professor at the Southern California College of Optometry at Marshall B. Ketchum University. I'm joined today by my friend and colleague, Dr. Dilsher Dhoot, vitreoretinal surgeon at the California Retina Consultants of America in Santa Barbara, California. Welcome, Dilsher.
Hey, Steve, thanks for having me. It's always great to be with you.
You got it. Today, we'll be discussing the therapeutic management of patients with geographic atrophy secondary to age-related macular degeneration. So, Dilsher, as we know, in 2023, the management of GA was revolutionized with the FDA approval of two agents for the treatment of geographic atrophy secondary to AMD. Can you provide a brief description of how these agents work?
Yes, Steve, it's been a great year. We've got two options now for these patients with geographic atrophy, and I think it's fantastic. We've been waiting for this moment, and so we've seen great utilization of both drugs. It's important to note that these are synthetic molecules. Up until now, our injectables have been biologics, which are produced from living organisms, but these are actually synthetic molecules. And avastin capsid pegol, which I'll refer to as ACP, the mechanism of action here is this is a pegylated RNA aptamer, and it is a inhibitor of C5 in the complement pathway. And by inhibiting C5, it slows inflammation and cell death that's been associated with the development and the progression of geographic atrophy. Pegcetacoplan also acts on the complement pathway further upstream and inhibits C3 and C3b, and ultimately C5, which is downstream. And pegcetacoplan is a synthetic pegylated peptide, and so inhibits C3, C3b, thereby reducing inflammation, opsonization, and cell lysis. And so we've seen that complement has been implicated in patients with geographic atrophy. We see complement products in the junctional zones. We see increased complement in these patients, and also, there have been genetic assays, analyses, and suggestions that, again, complement is heavily implicated in AMD.
Interesting. Obviously, a lot of work and studies went into getting these medications FDA approved. Can you briefly describe the studies that led to the approval of ACP?
Yeah, sure. I'll pause. When you compare these studies, it's a little bit, well, it's very important to recognize the inclusion exclusion criteria for the various trials, right? And so, giving you just kind of top level view, the ACP drug had two trials known as Gather 1 and Gather 2, and only looked at patients with non-subfoveal lesions. In contrast, and we'll talk about it in a moment, I'm sure, pegcetacoplan had the Oaks and Derby trials and actually looked at both non-subfoveal lesions and subfoveal lesions. And so you have to make a distinction here. And we know that non-subfoveal lesions tend to grow more quickly than subfoveal ones. And so that's important to note when you consider the trials. Now, if we go to ACP, I mentioned Gather 1 and Gather 2. Gather 1 was an 18-month trial, and Gather 2 was a 24-month trial. At month 12, we saw in both trials significant reduction in the rate of GA growth compared to sham. In fact, in Gather 1, this number was 35.4% reduction, and Gather 2, 17.7% reduction. At 18 months in Gather 1, we saw a 28% reduction compared to sham in the growth rate. And then in Gather 2, at 24 months, we saw that the every month group had a 14% reduction compared to the every other month group, which was crossed over at month 12. At month 24, this group had a 19% reduction compared to the sham group.
Very good. Very good. Can you now describe the studies that led to the approval of pegcetacoplan?
Yeah, so as mentioned, this study included patients with both non-subfoveal and subfoveal lesions. And Oaks and Derby were the trials, and they went out to 24 months and then were followed by a 3-year open label extension trial known as GALE. And so GALE is currently ongoing. We've seen the 36-month data, but pausing for a moment and looking at the 24-month data from Oaks and Derby, remember there were two groups here, patients being dosed monthly from the beginning of the trial, or patients being dosed every other month. And in Oaks, the monthly group had a reduction of 22%, compared to sham in the growth rate of the GA lesion, and the every other month group was 18%. In Derby, these numbers were 19% for the monthly and 16% reduction for the every other month group. What's exciting is that, when we go forward and we look at the longer term data, specifically Gale, the extension trial, we see that these numbers are increasing, right? And we see that there's actually a 32% reduction compared to sham in the monthly group, in the non-subfoveal group, and a 26% reduction in the every other month group. And so in this non-subfoveal group, we're seeing fantastic increases year over year, which is encouraging for our patients. We also see it in the subfocal group. And so, robust data to support the efficacy of these drugs.
So it kind of appears in a way that the longer you treat these patients in a way, that the more benefit they get. Is that an accurate statement?
Yeah, it is. And it's really like a carrot for our patients, right? Because unlike, neovascular AMD, where patients are actually able to see the improvements with the injections as time goes on, these patients really have to have faith in the clinical trials because there's no perception. In fact, as you consent these patients, you really have to set expectation that there won't be an improvement like you'd see in neovascular AMD. And so, as you discuss the trial results of these patients, seeing that patients do better over time is one motivating factor to try and keep patients coming in for these injections.
Excellent. So how have you started incorporating these therapies into your treatment of patients with geographic atrophy?
Yes, interesting, right? I think that you absolutely have to have a discussion about the drugs with patients with subfoveal or non-subfoveal lesions, so they're aware that these drugs exist, right? The discussion generally, can take some time. I've kind of have a concise method of doing this, and it takes me maybe 2 to 3 minutes to cover a lot of ground. But for patients, that's hard. 2 to 3 minutes is a quick time, and with the patients having variable cognitive function. And so, the brochures are very helpful. Both drugs have brochures, patient level lay literature. And so I provide these brochures. I plant the seed. Some patients are very motivated. They come in knowing that they want this drug, whereas other patients need time to think about it. And so, generally, we'll start a discussion. We'll talk about geographic atrophy, what it is. I'll refer them to patient websites for that, as well as providing brochures. And then, set expectations about what these drugs are and what they are not. I think that's super important as well.
No, I think you bring up a good point. I think that patient education, getting realistic goals and expectations is really, really important. Otherwise, they're just not going to follow through, I think. Like all treatments and all therapies, unfortunately, there are potential adverse effects. How are you mitigating the adverse effects and events associated with these therapies?
Yeah, so it's very important to be upfront about the adverse effects. And that's absolutely part of the informed consent that must be done with patients, right? And so, when discussing intravitreal injections, top of mind is endophthalmitis, so we certainly will discuss the risk of that. There were other adverse events seen in the clinical trials, things like ischemic optic neuropathy or conversion to neovascular AMD, and so. These events are discussed with patients. The risk of these events are discussed. The post-marketing data we've seen in the pegcetacoplan group, a rate of 1 per 4,000 after first-time injections for vasculitis that can be blinding. And so this is also discussed with patients in great detail. I think one method of mitigating some of these adverse events that I've mentioned is many of us are dosing on an every other month dosing regimen, which was tested in the pegcetacoplan trials. Though the ACP trials were monthly, some people are extrapolating the data and also treating every other month with ACP. Specifically with pegcetacoplan, we know that the adverse event rate is mitigated to some degree with every other month dosing. So that's one method. I think on initiating therapy, we've all kind of learned from colleagues in retina and the cases we've seen of things like vasculitis that it's probably not wise to treat both eyes on day 0. And so generally we'll treat one eye, generally the worst seeing eye, potentially even considering an off-label dose, which would be maybe a half a dose. And by doing this, testing that eye in a way, making sure that the patient does not have any vasculitis or inflammatory reaction to the drug. And I think many of us are very cautious on after that first injection. If the patient does well, we'll introduce it to the better eye if that eye is eligible for it, and we'll proceed forward and treat patients every other month. So that's some of the measures we're using, to mitigate those risks.
Fantastic. So as optometrists, you think we should be on the lookout, obviously, for any signs of inflammation or, iritis or certainly endophthalmitis. These are some of the things we should have in the back of our mind if we're co-managing these patients.
Oh, absolutely. Yeah. So if a patient comes in, I mean, and as you know, some of these patients are traveling great distances to their retina provider and may have a local optometrist that may be someone that they reach out to first, right? And so if a patient reports a recent injection, and really it's any injection, a recent intravitreal injection, and they have decreased vision or pain, or increased, vitreous opacities, floaters, the antenna should be high for potential complications of injections. And so, yeah, certainly you're right. You should be on the lookout for these things.
Fantastic. What education would you like your referring optometrist to provide to these patients with geographic atrophy before we send them over to you for potential treatment?
With patients that have not, heard of the drug or don't necessarily understand what geographic atrophy is, it's really nice for them to have multiple touch points with healthcare providers to learn, about the disease state and the potential therapeutic options, right? And so I think, setting the foundation or for what is macular degeneration or geographic atrophy. Often, we do analogies. It could be like a balding spot in your head or a bare patch of grass, and it grows. And so things like that are nice. So patients start to understand, what is geographic atrophy, and then introducing the concept of a therapy that's not going to make you better, and it's not going to stop geographic atrophy or reverse it, but potentially slow it down based on the clinical trials, allowing for the patient then to potentially have a few more months or maybe even a year or longer, depending on how long they're on this treatment, of quality vision, right? And so, providing patients with this type of information and setting the groundwork, I think is very helpful. And when they get to us, we kind of expand on that. But if they've heard something already, these patients are coming with a more open mind, I think.
Yeah, and I think it's important. I think I agree with you. I think it's important for them to hear the message more than once, to hear sort of the same message more than once, that it slows down the progression, moving forward. Hopefully will give them longer time with usable vision, but it doesn't fix any damage that may already have been done. So I think those are all important points. I like to use the bald spot or hair thinning analogy. It's kind of hits close to home. So I like to use that one. Any summary or final thoughts about these exciting therapies that you'd like to leave us with tonight?
Well, I think it's exciting times, Steve. We've got 2 treatments now. It's great to have these in our toolkit, and this is not the end. Just as with neovascular AMD, we've seen the evolution of treat therapies for neovascular AMD. We're going to see more durable treatments, more effective treatments. The pipeline for GA is very robust, and treatments with other mechanisms of action. It's a very exciting time to be in retina. And so, I like to give patients hope that, right now you might be starting out with injections that are quite frequent every other month. And of course, they have to come in with their caregivers, and, there's a high burden. But over time, we'll have, other treatments. We'll have treatments that, potentially even are one-time treatments like a gene therapy, and so we give them hope and we get things started, and then we'll see how this evolves, But for now, I think that, it's great to have these treatments, and we're actually seeing, there's been some criticism that visual function benefit was not shown in the clinical trials. But in fact, we've actually seen now one pre-specified endpoint being met with the pegcetacoplan trials when it comes to microperimetry at the 3rd year. And so I think that there's been an evolution in understanding how to measure vision in these patients, and what's the best mechanism. Visual acuity doesn't always give you the whole story in this population, and so other mechanisms like microperimetry are being very helpful, but of course in a post-hoc fashion. But it's exciting. So I think that it's great to collaborate with our optometry colleagues so we can identify these patients and then ultimately provide them options.
Excellent. Yeah, I agree. I think it's a very exciting time. It's hopefully just the first step in treatment for geographic atrophy that will lead to even better and more exciting treatments for geographic atrophy and wet and dry macular degeneration moving forward. So Excellent. So thank you, Dr. Dhoot, for the excellent discussion today, and thank you for listening. Please remember to take the post-test and evaluation to receive CE credit and to tune in for additional episodes within the podcast series.